I think it's just very difficult for anybody trying to take care of loved ones, knowing that this person will be gone in 6 months.
Having a terminal illness, facing death, there's nothing more challenging that we'll experience in our life.
Fortunately, there is a tremendous amount of growth that occurs in that period of time if the patient and family are receptive to it and can provide for a very healing experience even in the face of death.
One of these days I'm going to die. I never thought I would get cancer, and I still can't believe that I have it, but if I do, it might as well be that as something else. And we do not wake up every morning thinking, oh, maybe this is the day. We wake up every morning thinking we have another day.
Dying and also taking care of someone who is dying is very difficult, both physically at times, but mostly emotionally.
I think if a person has been diagnosed with a serious illness that may be terminal, they need to discuss all of the treatment options with their primary doctor. They need to discuss what options might lead to a cure of their illness, and if a cure is not likely or impossible, they need to discuss what options are there so that their symptoms may be managed appropriately for the rest of their life.
Even though you're dying, you still have a life. You know, we're not giving up on you yet.
The pain that cancer brings by far outweighs any level of pain that I have ever experienced in my life. And yet there are still measures of pain control out there that are effective.
Pain is a very common symptom that we see with most terminal illnesses. Certainly in cancer patients, a large percentage will have some degree of pain that probably will increase as their illness progresses.
So what we seek to do is relieve pain and physical symptoms and let patients do whatever it is that they want to do with their time without having to be concerned about physical problems.
Pain should be controlled in up to 95% of cases.
If you treat pain early and try to prevent it, you use less medication, the patient's more comfortable, they're more alert, the quality of life is much better.
You can feel good when you're sick.
Pain medicines can be delivered in multiple ways. Not only the traditional pill for pain relief. We do try to avoid giving injections for pain relief because injections themselves are painful. Pain medicine can be delivered transcutaneously through the skin as a patch or a gel. They can be delivered by mucous membranes absorbed other than through the mouth. We also take advantage of non-pharmacological ways of relieving pain, including massage, water therapy, oxygen, neurostimulation, those type of things. Addiction is not a problem in patients who are dying and needing appropriate opiate narcotics for pain relief.
There's a difference between addiction and tolerance. Anyone who takes a narcotic medication will develop what's called tolerance, and that means that it will, over a period of time, take a gradually increasing amount of medicine to get the same effect.
There are pain receptors in the central nervous system that are affected differently by the medications depending upon whether they're used for pain relief or whether they're used for other recreational purposes.
Patients who take pain medicine for pain become more functional. They go to work, they interact with their families, they get out of bed, and they become more like themselves. Patients who take pain medicine to get high become less functional. They go to bed, they lie, they cheat, they steal, and become less like themselves.
I've never seen anybody get addicted to pain medication when they have real pain.
If you need it get it and take it. There's no need not to. You're a patient. This is it, kid. You might as well live it up and enjoy it.
There are some types of pain which are not physical in nature. There's spiritual pain and emotional pain, and medicine doesn't fix that. But providing that patient with physical pain relief allows them to focus on their other needs.
Oftentimes, in focusing on just the spiritual life of a person, you can't alleviate pain because pain is a part of it. But it's something you have to address and seek comfort for. Many times people, especially loved ones caring for someone who's dying, will say, you know, if I only had more faith, I know that I wouldn't feel this bad. Or, oh, I know I shouldn't cry. I know that, you know, he's going to be okay, but I just... And, you know, my answer to that is I think that the pain that you're feeling is just a testament to the love that you're feeling.
Each individual experiences this in a different way, and it is very difficult to be general about the process.
Some people have a long, gentle decline. Some people have a very fast, sometimes not so gentle decline, depending on the illness and the patient. And all of that, each of those variations is normal, and there's no way to predict ahead of time how exactly the dying process is going to go for each patient.
I've learned over the years that it's very difficult to predict a person's length of time remaining, and generally try not to do that. But there are some things to look for. The first thing that I see is just progressive loss of function. By the time a person has, say, 2 months or so to live, often they're much less able to ambulate. They become short of breath easier. Their appetite diminishes. Often they begin to show signs of weight loss. They are more fatigued. Their mental alertness is less. They're at times confused. By the time we're down to a month or so, all of those processes are just more noticeable. They still may be able to ambulate. They still may be able to carry on appropriate conversations for short periods of time, but they often are in and out of sleep. Some of this depends on their medications. I mean, the medication certainly may worsen some of those symptoms. We try with good pain management to avoid sedation as much as we can, but the later the illness is, the more sedation occurs generally. By the time a person is down to a week or so remaining in their life, they may sleep most of the time. Certainly their energy level and fatigue levels are going in opposite directions. Their oral intake of food and water, nutrition, is generally very minimal. They may or may not have more pain symptoms that need to be managed, and because of that need medications that make them more sedated. Respiratory distress often occurs, more shortness of breath. That becomes a bigger problem as the latter days approach. And in the last hours of life, or sometimes the last days of life, you see some changes in vital signs: lower blood pressure, faster pulse, perhaps a fever, again, less alertness. Usually by the last couple of days of life, a person is rarely able to actually get out of bed by themselves.
The thing that we notice and hear about the most often is decrease in appetite and decrease intake of food and liquids. That happens sometimes several weeks before death.
That can be a distressing, disturbing symptom, more so for the family than for the patient. Not eating or drinking is probably not a painful process. A person is probably not uncomfortable when they don't have a good oral intake. But many times that's a distressing thing for a family member. It's a sign, it's a reminder that the illness is worsening. And we try to educate the caregiver to know that the person is not uncomfortable, that they should be allowed to eat or drink to their desires and not to force food, which often may cause some stomach problems, some GI type distress if they overeat at that stage.
As the time of death gets nearer, oftentimes the feet and hands will become cool and then cold and sometimes blue or mottled, which is a splotchy appearance. The nearer the patient gets to death, the colder in general the body tends to be to the touch.
Confusion is certainly a common thing that occurs in the latter stages of a dying process. Again, there are many reasons for that, including medications and side effects from medications, the fact that the illness may directly affect the central nervous system. Hallucinations are not unusual.
The person who's dying may sit there and talk to someone who is not there. They may be people that the dying person knows. Maybe it was a family member or a loved one who has died before, or it may be someone that is unknown at all.
And there might be hallucinations, there might be things that medications could help with, but it's important to try to distinguish that probably from real healthy, needed conversations that they're having or things that they're kind of re-experiencing.
People sometimes start to use euphemistic language about travel. I've talked to people who, they haven't driven in months, but they need to get the car gassed up, or they're looking for maps, or they want particular shoes. So people will start talking about, or trips that they're planning, and sometimes this can be very confusing to family members because you're thinking, oh, he wants to go on a trip, and we're not going to go on a trip. How do I let him know that? It's the euphemistic language. They are going to travel, but this is they're not going to need a car, and they're not going to need a map, and they really don't need their walking shoes. But these are the sorts of things that people, attach to it. They're to leaving. It doesn't mean that a person's going crazy. It's just time. And there's certain things that happen when the time becomes ripe.
It's common that respiratory distress or respiratory problems are present in the latter stages of terminal illnesses.
There will come a time when their breathing is very irregular, where they'll breathe several times deeply and then have lapses where they don't breathe. And they'll breathe several times deeply and have lapses where they don't breathe.
It may be disturbing to a caregiver, but I think with proper education, a person realizes that that's one of the physical signs of approaching death.
Toward the end, it is common for patients to do something that's called fish mouthing. That is when breathing slows down quite a bit, the mouth is closed, and there's a certain amount of pressure that has to be exerted to overcome the resistance of the lips, and so that results in a fish-like appearance to the mouth and what appears to be straining to breathe. In fact, it's not straining to breathe, it's the pressure of the air coming in and out, overcoming the lips. It is not painful for the patient.
Most people are not clearly lucid at the time that they die. They've gone into some type of situation where they're not totally aware of what's going on, and most of the time are not in pain and not particularly distressed by the situation.
It's reported anecdotally that people often postpone their deaths for some event. It's not at all uncommon that a person lives to an anniversary or a birthday or a graduation date or some milestone that a family member or themselves may be reaching. And they may very well rally for that event or something associated with it and then pass peacefully a day or two later. I mean, that is something that we do see.
As my mother was dying, less than a week before she actually died, she was up and around, chipper and eating well, and everybody was home. We had all come home and everybody was there. It was just a wonderful experience that we had. And then, but it was just a nice rally that was occurring. and it gave everybody, to a certain sense, some sense of hope. And in fact, my other family members were starting to talk about going back into treatment once again. But it was just a kind of a false thing that occurred.
The dying experience is different for everyone, despite the fact that the physical milestones are generally the same. The emotional things that happen and the growth that happens is different for everyone.
Profound questions of faith arise, and or just unbelievable feelings of anger come up. Anger toward their God, anger, at their faith. I've done everything that I was supposed to do, and you didn't protect me from this. You didn't save me from this. And those, especially if a person is verbalizing those feelings of anger or those questions of faith, it's sometimes very disconcerting for those people around them. And the people around them will be doing all that they possibly can to mollify them. And it's sort of like, I always feel like you're trying to squish everything back into the bread sack or something. It's gonna be okay. And that's okay. I believe that God is big enough to handle these feelings of anger. We're created with a myriad of feelings and emotions, and one of them is anger. One of them is frustration. One of them is fear. All of those things can be held and encompassed in the magnitude of God. So it's okay for a person to be asking those things. Those are profound feelings, and those are profound questions, and questions that can lead to profound answers. And as I've said, a person's spiritual life continues to grow to death and expand as their physical body may start to deteriorate. So those questions, those profound questions, can still lead to a profound answer even up until death. Sometimes that's disconcerting and can cause a great deal of fear for caregivers, because caregivers may not see that resolution. Caregivers may not hear that the answers were given before the patient dies. And sometimes it's a real painful place for caregivers. They think, she died swearing at God. Well, she was still in relationship with God, she was still, she was angry at God, but she was still in relationship. And surely a God who is compassionate and loving is able to understand that kind of anger and hold someone in that anger.
People are generally really uncomfortable with the whole subject and being around someone who's been diagnosed with some kind of terminal illness. I think it's important to try not to change how you've always reacted to that person, to still joke with them or be how you always have with them.
When you come and you talk to them, you don't have to talk about the fact that they are dying, or that this might be the last time that you're going to see them. I think you just carry on as normal of a conversation as you can and talk about memories and things like that.
It's amazing the numbers of people that will come in and talk to a person who's sitting in the chair beside the person who's in the bed and say, well, what does he want? How is he feeling today? What is he doing? When you could talk to him. And even if a person is comatose or sleeping, that you say the things in front of him or her that you would want him or her to know or to hear.
They are still there. They're probably aware of who's in the room and of what's going on.
We're still people, and we're still alive until we're dead. And we need to treat each other that way. So we need to use the same manners and graciousness that we would at all times with each other.
If you want to do something for that person, I think just coming in and kind of seeing what needs to be done is important. I mean, their household might be in chaos, and just washing dishes or walking their dog. I think real small, genuine things like that are really appreciated.
The simplest thing for anybody to do to me would be, at times, just to be there. Not necessarily to do anything, not necessarily to say anything, just to be there. That in itself helps to instill friendship and confidence, warmth. I can feel you there. Even if you're sitting at the end of the bed and I go off to sleep, I can feel you there in my sleep. And I want you to be there.
Disfigurements can be difficult, knowing how to approach a person. But that also can be sort of like the elephant that's in the room that no one is talking about.
Friends don't want to come because they say, oh, I don't want to see her looking like that. I want to remember her as she looked. Well, this is as she looks. This is a part of her life, and this is what she looks like now.
Those people might not have as much contact as they're used to with other people. They might be more lonely. They might just need someone to hold their hand. They might not be touched as much as they had been. I think eye contact is really important, no matter what else is going on with someone's face. And then maybe after just being there and trying to be present again, of just being with them, then just asking how they feel. How would you like me to act? How would you like me to be with you? Are you comfortable with this? Again, I think that's a real gift, because most people are just afraid to do that, and it's sort of the simplest, obvious thing that maybe can feel like the hardest, but once you've done that, I think that builds huge trust.
When it becomes nearer to the time of death, oftentimes the patient, even if he or she is able to talk and able to be awake, becomes just less interested in what's happening around them. I've talked with family members who are trying to plan this great family reunion, have everyone come in, and the grandfather is going to get to see his grandchild that he's not seen before. And the grandfather, who's the patient, is just not very interested in it. And it seems universal that there's a shutting down. Just as there's a shutting down of the body as a person starts to die, you might, your kidneys start to make less urine, your bowels start to work more slowly, your lungs work differently, and your heart works differently. There's something that happens internally with our relationships, and I call that what's happening spiritually, because I think it's our spirit that causes us to seek relationships with others. And our ties to those sorts of things, to family or friends or activities with work or what's going on in the world, start to lessen some. It's as if the threads just start to become thinner and thinner and thinner. And that's very disconcerting sometimes to families and loved ones. They think, well, why isn't he interested anymore? What is happening? Maybe he's just depressed. Maybe we need to not do something to keep him from being depressed. But I think it's just a natural shift.
Caretakers need to recognize that they do need that space to be by themselves. And it's not that you're abandoning them, and it's not that they don't love you anymore, but there's some issues that they need to take care of. Spiritual issues, emotional issues, a lot of closures, and sometimes when that happens, they are breaking away from the family, and it's hard to let go.
It's okay to say goodbye.
Let them know that you still love them and that you will be all right if they do die.
You have to say, I love you, but I'm going to be okay. It's okay for you to go. You need to do what you need to do. And then telling people just to take steps as they're ready. Not that they feel like they need to go or that you want them to go, but when they're ready. And just even that you understand that they can't stay.
Knowing that you're there, that is the best gift I think you can give them. Just reassure that they're there and that you're okay with them not talking. You're okay with them not being there with you. If they know that, then it's easier for them to go through the different stages that they need to go through in order to have a peaceful death.
This is a long process, and we as caregivers, we don't know when it's going to end.
If you can have a certain amount of time every day or a certain number of days a week where you can get out of the caregiving situation and take care of yourself for a certain period of time, that then allows you to be a more effective caregiver because you're not drained and stressed all of the time.
Just simply getting physically away from the situation from time to time can help in creating some relief from the intensity.
What I recommend that caregivers do is take the time that they have carved out for themselves and use that time to do things that are important to them. That's different for everyone. It may be exercise, or it could be painting, or some sort of outlet that's specific to the caregiver, and not for example, stopping taking care of your father and starting to take care of your children during that hour, but carving out time that is specific to the caregiver and meets a need of the caregiver.
Some of the things that happen when a person is sick, some of the things that people say and do when they're confused, we just have to face it. Sometimes it's funny.
Humor is one of the good things in life, and this is a time when you need all those things.
It's appropriate, it's helpful, and it rebuilds a foundation that sometimes feels like it's crumbling.
Yeah, I'm dying, but hell, so are you sometime. I'm just going to do it a little quicker. I can joke about it. I couldn't in the beginning, but I've got to a point of acceptance, and I can joke about it. So do the same with me. Don't feel that you've got to be overly careful. Don't feel that you're standing on a crate of eggs. You're not.
We are helping ourselves get through whatever we have to get through when we laugh. So we've got to laugh through all of this.
For the caregivers, it is sort of a double duty of trying to care for this person physically, trying to be there for them emotionally. And so it's a really critical time that they need someone to also care for them a little bit.
To be able to come and talk about their fears, talk about how angry they are, how upset, how unfair it is, whatever they're struggling with.
That's a huge burden lifter.
Because if they can have a place where they can deal with all of that stuff, then that's all those emotions won't be pulling them down so much.
Just having one other person that kind of knows what's going on and that cares is really important at that time. Feel like you're not out there alone.
People seldom listen to this, but the one piece of advice that I really want people to know is that they can only do what they can do, and that people need to go easy on themselves. You really never get to be a master at caring for someone who's dying, because say you care for your sister who's dying, and then you find yourself a caregiver again, but now it's your husband. And you never cared for a husband who died before, or even if you did, it was a different husband. And so it's always new, and it's always painful, and you always find yourself in a tender and new predicament. So you have to be gracious with yourself.
You're doing all you can do sometimes, and that's enough, and everything you can give is enough.
When I try to tell people, this is not all doom and gloom, I think that that sometimes that's interpreted as, oh, well, this isn't going to feel as bad as it feels. It's going to hurt. Your heart will be broken.
Some people sort of take this as a wake-up call and will decide there are certain things that are important, and they're going to just focus on that and let people know how they feel about them or say things that have needed to be said.
We get really close together and we cry a lot. And we laugh some. Smotely cries a lot, and I wouldn't give anything for it. That was the best time with my brother and me and my family.
What greater satisfaction can there be, it seems to me, than to assist in easing this process for someone else?
It is a cycle of life, and it's a part of life, and it's an opportunity that doesn't happen many times.
It can be really bringing together everything that was good about life.
This experience together has brought us closer together. With a little effort, we've made the experience not only tolerable but positive.
When we begin to pull death back into our homes and back into our lives, into our hearts, as a part of life, that we will claim a deeper meaning to life.